Move on to our next speaker, Dr. Neha Midha. She's a consultant at the Avantika Eye Hospital at New Delhi, and she's going to speak to us on role of micropulse laser, CPC. Over to you.
Thank you, and thank you AIS for having me here today. So before I begin, acknowledgement to my mentors. And in a continuation of our quest to find an ideal IOP lowering modality, I think micropulse is just another candidate which is trying to make its space. So I'll be just covering my presentation under these headings. So what is micropulse? Basically, there's a continuous wave of laser which we are chopping down into repetitive short pulses of about 810 nanometer diode laser, so that you reach a coagulative threshold in the targeted pigmentary tissues of the ciliary body. This laser has a duty cycle of 31.3%, which means the laser is delivered for 0.5 milliseconds while it is switched off for 1.1 milliseconds. So this allows heating and cooling, heating and cooling. So this heat and cool alternate causes lesser thermal dissipation and lesser damage to the collateral tissues as compared to the continuous wave CPC that we do earlier. So the mechanism of action for this micropulse is not fully understood. However, the few of the proposed theories are partial inhibition of the secretory activity, similar to continuous wave, but much lesser. Second is the increased uveoscleral outflow, which has been proposed due to increased choroidal thickness that was observed after the procedure, and a pilocarpine-like effect, where the contraction of the ciliary body muscles pulls the scleral spur more inward and posteriorly. So if all of these theories are considered to be true, the micropulse actually is acting like a combination of anti-glaucoma medications, where we are increasing the aqueous and the uveoscleral outflow, and at the same time we are decreasing the aqueous humor production. So this technology is being marketed by mainly Iridex and Quantil, and these are the probes, how they look like. So the procedure is usually done under a peribulbar block, and a viscoelastic or a lidocaine jelly is poured over the surface. If we are doing an Iridex one, which has a foot plate, we don't need to use an eyelid speculum, because that actually causes an obstruction in the sweeping movement. And while if you're using a Quantil probe, it has a fiber optic kind of a probe, very small tip, so I prefer to use a speculum. The sweeping movements have to be adequately slow and gentle, and the settings that are used are basically the power ranges between 2000 to 2500 milliwatts. We are giving about 80 to 90 seconds per hemisphere, and the sweeps, how much we should do in those 80 to 90 seconds in one hemisphere, is actually a big discussion. So this can be understood by the fact, for example, if there's a burning flame and we pass our finger through it, if we are going too fast, we might not feel any heat, whereas if we are going too slow through that flame, the chances are that we might burn ourselves. So slower the sweep, more is the thermal absorption. So even with the same settings, if in those 90 seconds I am doing only 3 sweeps, the chances are that I'm causing more, I'm likely to get more lower IOPs and higher complications. However, if I am too fast, I might not get any efficacy at all. So this was the same thing that was shown by Sanchez et al. And they found that if the total energy delivered varied between 112 to 150 millijoules, it gives us a good balance that we are not getting too many complications, and neither we are getting too many failures. Looking at some of these studies, so this was a study which looked at micropulse being used in eyes with advanced glaucoma but good central vision, and they found that about 85.4% patients had an IOP reduction of more than 20% at the end of, say, on an average of 12-month follow-up, and about 80% of the patients had more than one medication reduction. But what is important to see here are the complications. That out of these, 10 eyes had a vision loss of more than 2 lines, out of which 5 had cataract progression, and the other 5 had CMA, iritis, or glaucoma progression. Similarly, in this study of about 207 patients with a mean follow-up of 18 months, they found that we had decent IOP reduction. Even at the end of 24 months, there was 32.6% patients having a reduction of more than 20%. But again, look at the complications. 29 eyes with reduction in BCVA, 7 eyes going into phthisis, and 1 eye with chronic hypotony. However, yes, these eyes, the studies which are reporting higher complications have used higher energy settings. Now, this study was done at RP Center where we tried using micropulse laser in phakic PACG patients who have not undergone glaucoma filtration surgery, and we found that more than 20% reduction was achieved in about 65.6% patients at the end of 12 months. And in our complications at 12 months, we found that 9 eyes had a drop in visual acuity, which was due to cataract progression, and transient CMA causing a loss of more than 2 Snellen lines was observed in 1 eye only. So often the question arises that is it a replacement for trabeculectomy or a tube? So this study tried to answer that question, and they found that more than 30% reduction in IOP at 12 months was observed in 73% of patients who underwent AGV, while only in 33% of patients who underwent micropulse. So yes, it may not be a replacement to these filtration surgeries at present. So my patient selection is particularly the patients who have had a prior glaucoma failed surgery, patients who are unfit or unwilling for incisional surgeries, or as we discussed the importance of conjunctiva, how important it is for a filtration surgery. If you have a scarred conjunctiva like a post-PK glaucoma, then I would consider this as my primary procedure. So I would, moving towards the end, I would just like to do a quick SWOT analysis for this technique. So talking about the strengths, it's decently effective. It is very easy to do, take couples of minutes. It's a portable machine. The post-op care is not much. The complication rates are there, but not very high. Even you don't need an operating room or a microscope to perform this. Weaknesses here are, the mechanism of action is still not well understood. The laser parameters we are not very clear on. Most of the data that is published is retrospective. The effect wanes off in 6 to 12 months. And the position of the anatomic, the variations in the anatomic position of the ciliary body is also a question. But however, the opportunity here is that I see it as a great tool in my armamentarium, that in advanced glaucomas where the patient or even the surgeon is very scared to do a trab with a very small island of vision left, this somewhere comes in between and gives you a ray of hope. The threats, as I discussed, this is being tried and being marketed to be done in eyes with good visual potential. So in eyes with good vision, even minor side effects like mydriasis are extremely important. So this thing has to be kept in mind, and definitely we do not have enough data on retreatments. So looking into the future, we need more and more prospective trials. We need to understand and standardize the sweep velocity. We need to understand in which type of glaucoma does it works the best, and we definitely need to understand that this works better for treatment naive or failed surgeries. Thank you. These are some of my memories with Dr. Andre Mermu, so I just thought of sharing them here. Thank you.